Nick Majerison here. Welcome to Top Med Talk. Time now for today's Top Med Talk, which is called CPET for Risk Stratification in Major Urological Surgery. It's from James Prentis, and it was part of the POETTS Annual Congress, which was, of course, held in July of this year at the Institute of Engineering and Technology. Have a listen.
Top Med Talk.
Thank you, Mike. Next up speaking is
James Prentis.
Yes, Prentis from Newcastle. Again, a user of CPET for research and for pre-op for major surgery. He's going to talk, and this is where I'm biased, I want to know about CPET in urological patients so I can convince my surgeons. Hopefully you're going to give me the evidence for that.
I don't know quite yet, but thank you very much. To be quite honest, I don't really think I really need to say very much more after the talk before. It sort of tells us that CPX predicts complications. I'm a consultant anaesthetist up in Newcastle. We've got a big urological department, and there's been a big drive recently to have a look again at all our outcome data for a number of reasons that I'll go into as the talk goes on. It's a slightly forgotten speciality, especially in our hospital. They rarely go to critical care. They may go to our post-anaesthetic care unit, maybe for the night. But they've also got quite extensive comorbidities. They've got cancer patients who may have had chemo. They get stomas that can go wrong. They're often anemic. They've got a lot of comorbidity. And they do have a very prolonged length of stay, surprisingly so. Now, some of that's to do with training the patient in the management of their ileal conduit if they're having a cystectomy. But they have got considerable morbidity and a relatively high mortality rate. And in 2013, we did a small observational study of older patients undergoing cystectomy, and it showed that your anaerobic threshold was predictive of length of stay and complications based on the Clavien index. And cut-off values, as we all like them, it came out about 12. Since then, it's gone under the radar, and we haven't really had a good look at things to see whether anybody else has published on it and what they were feeling and what they found. But there has been a few papers that have come out, one in 2015, 105 consecutive patients for cystectomy, and I am really mentioning cystectomy patients in this talk. We have some early data about the prostates coming along. We've done over 600, so it's taken the longest time to look through all the data. Logistic regression analysis in this paper showed a low anaerobic threshold, a high VCO2 and hypertension as significant factors in predicting complications, and those patients were 5 times more likely to have a complication at 90 days than patients who were fitter. However, there has been a couple of other conflicting papers. One looked at 60 patients, 25 were excluded from the analysis, mainly because they didn't have surgery because of their low anaerobic threshold. And unsurprisingly, there was no difference in their length of stay or complication rates. And another one I just found online, there was a website, and I can't find where this paper was published or whether it ever was. 82 patients, median length of stay of 10 days again, major complication rate of 13%, mortality rate of 3%, AT, peak VO2, VCO2, no difference between those patients who had a complication or not. But they did actually give us the actual complications that the patients had. And I really don't think a CPX test would be able to predict an anastomotic stricture, nephrostomy and stent insertion, or a small bowel injury, or that there was, I think, a rectal injury that required a colostomy. So it's a bit tricky, the data that's out there at the moment. So we've had a big drive to have a look again. And I also don't really like the Clavien index that we seem to be focused on within urological surgery anyway. We often say that a Clavien greater than 3 is what we would include in a complication rate. However, that's the ones who require surgical, endoscopic or radiological intervention, which I really don't believe that a CPX test could predict. Clavien 2 is also pretty wide-ranging, I would say, from someone who needed a drug that was beyond their grade 1 complication, so maybe a bit of antibiotics because they had a urinary tract infection from their catheter, or some other reason, to needing blood transfusions, TPN, etc., etc. So it's a very wide range of differing complications. However, the British Association of Urological Surgery have produced, for the surgeons, what is a high-risk cystectomy patient. So salvage cystectomy, so they've had a definitive treatment that has failed, so they may have had radiotherapy first, and have gone on then to have a cystectomy, very high risk. I defer to my surgeons about the complexity that makes a cystectomy to be. However, they're putting an AT less than 11 is the second biggest predictor of complications or complex cystectomy. How they came to that, I don't really know, other than, again, looking at the previous evidence that's gone on. But they have included other things like anemia, age, Charleston index, high or low BMI in predicting the higher risk patients. So this is our data that I've just looked back over again for the last 4 or 5 years. Single centre experience, it's very early data, it's a retrospective review, and I've been pestering my surgeons to give me the outcome data. Well, full CPX data, but not all the outcome data, but you have got length of stay to go along with it. We're operating on a very fit group. The anaerobic threshold was 15, the peak VO2 was 19, VVCO2 was 27. Our median length of stay was 12 days, I must admit. Our enhanced recovery is not perfect by a long stretch of the imagination. Mean length of stay of 14 days. Complication rates is slightly higher than previously mentioned, but 21% at a Clavian score greater than 3. And mortality 2 out of 185, so it fits in with what we're saying. It's about 1%. So if we just had a look at the complications, so the Clavian greater than 3 or not, that's what our surgeons seem to like. Big difference in your length of stay if you've got a complication. We all know that. That's not new. And when we had a look at the anaerobic threshold, there was a difference. There was a significant difference in the patient's anaerobic threshold and the peak VO2 between those who did and didn't have a complication. But there's still a pretty fit group. There's still, an AT of 13, we'd be passing through on the whole. But halfway through, things have changed. We now have 2 robots. All our urological procedures are done robotically, and we've also got ENT doing it, cardiothoracics doing it, hepatobiliary doing it, and we've got our first Whipples planned in a couple of weeks' time, which I think hopefully someone's going to have a very long book to read. So what is this robot? Well, it is pretty impressive when you see it. Essentially, it's, I think, to take the tremor out of the surgeon's hands so they can drink as much as they want beforehand. Is that right? Is that basically what a robot does? But it does have much greater range of movement than your normal wrist, so you can get right round to do the stitching. And what are the potential benefits? Well, they say that it's shorter recovery time, fewer complications, reduced surgical-related trauma because the port sites are better, reduced blood loss, reduction in pain, reduction in risk of infections, a quicker return to normal daily activities. Now, I don't know how much of that's proven or not, or what is because what the surgeons like saying to us. And for the surgeons, it means that they can sit down for the entire case like we do, rather than having to stand there. Enhanced dexterity, they're not as tired at the end of the day. I'm not sure whether we can turn around and pay millions of pounds not to be as tired at the end of the day, but there you go. And when you can do this, it must be better in my eyes. So we'll just play it a little bit because it's quite interesting now what happens with it. But so they can peel a grape. So it must be better. It's got to be better than anything that's gone before it. It must be. So is it? Well, when we split up our patients, we had 100 who have gone through robotic cystectomies. We had 85 that were open. The length of stay was less. Still pretty long from my point of view, but it was less. The mean length of stay was 10 days compared to 13 days. This was the CPEX results. Our anaerobic threshold in the patients having a robotic cystectomy was 16 and the peak VO2 of 21. Significantly higher than the patients undergoing an open procedure. Why? Well, I asked my surgeon this. I said, this is what we've got. His was, I felt like I was under the microscope for every case I was doing. Nothing could go wrong or wasn't allowed to go wrong, so we made sure we picked our patients. So they were picking a deliberately low-risk group to operate on because they didn't want things going wrong, which is fair enough. And then it comes to how many do you need to become competent? And there's always a learning curve. Of course, there's always a learning curve. Certainly for our prostates, we're increasing up from doing 2 a day to 3 a day. The length of stays are definitely dropping. They're going home the next day on the whole. Cystectomy, far more complex than a prostatectomy, and the learning curve, therefore, is probably greater. So just having a look at the complications of our robotic surgery group, I've got about half the complication rates. So I've got about 50 patients who have got complications, proper complications on that have been assessed. There was a 10% who had a Clavian score greater than 3. Numbers are small, but there may be a signal for their anaerobic threshold. It was 13 compared to 16. Very much like what it was in the other groups. Just using our cut-off of 12, just picked it out of the air, there was a significant difference in the length of stay if you were more unfit by about 6 days or so. So what really I'm asking, and why I've really come along to present that work, is it's probably not the right time, or wasn't the right time, to look at this data. The surgeons were undergoing a dramatic learning curve in a new technique, and probably to actually go ahead and publish this data is the completely wrong time. We have moved forward. All our cystectomies now are done robotically. I can't remember the last open cystectomy we did, and the length of stay is definitely dropping. We've probably moved or moving past our learning curve, and we're more assured that the complications we're seeing have been minimised down to the lowest level, and we're not having the surgical mistakes that we have seen. And what I really want is whether people want to go ahead and look at major urological procedures undertaken by the robot to see whether cardiopulmonary exercise testing is an appropriate risk stratification score for patients undergoing robotic surgery. And also, when I say Clavian score is absolutely rubbish in my eyes for assessing for complications. It's probably fine for the surgeons, but we definitely need a better way of looking at post-operatively at our patients. Thank you very much.
And don't forget, you can meet the Top Med Talk team. All you need to do is turn up at one of our events. Check out ebpom.org for more details. ebpom.org. Our next big event is between the 28th and the 30th of September in Chicago. That's EBPOM USA, the Chicago Masters Course, Perioperative Care Practicum. Between the 28th and the 30th of September. ebpom.org for more details. That's ebpom.org.